Okay, so as noted, am an anesthesiologist, have been working here in Englewood since 1992, and I'm going to talk a little bit about anesthesia today. Hopefully, it's not too technical, and hopefully, there'll be time for questions if you have any afterwards. I'll give a brief an introduction, a brief history, talk a little about what the purpose and what we get out of preoperative testing, how else a person can prepare for surgery and anesthesia. I'll talk about general anesthesia and how it's done, which is the whole focus of this lecture, how we monitor patients, and then what are considerations postoperatively. So when we first start my anesthesia residency, I'm told that there are 5 goals of the anesthesiologist during surgery or another procedure. We want to make sure there's good pain relief both during the surgery and, if possible, afterwards. We want to keep the patient unconscious or sedated. And basically what I tell people is that my goal is at the end of the procedure that you say that that wasn't bad. If somebody sometimes is awake during sedation, we still usually offer medications that give them anesthesia. So sometimes people have to actually cooperate depending on the type of surgery, but one of the goals is to make sure they don't really remember it. During surgery, the surgeon needs the patient to be immobile. It's no good if the patient is trying to get off the table, even if they don't remember it. So we have medications and techniques to make sure that there is good operating conditions for the surgeon to work. And then, of course, we want physiological stability with as close to normal heart rate and blood pressure, oxygenation, etc., as possible. Besides general anesthesia, there are many other things that we offer, and depending on the type of procedure and what the patient wants, we may use one or more of these. For example, if you have a cut and you go to the emergency room, you might just get local anesthesia where the physician in the emergency room just injects local anesthetics and can suture the wound without any other kind of medications at all. For procedures that might be uncomfortable or the patient has a lot of anxiety about, there can be what is called conscious sedation, and that is intravenous medication given by the doctor doing the procedure with monitoring by an RN. It's a normal, regular RN, but they do have some extra training regarding the anesthesia and what needs to be monitored. Also, you may know that in OB, if the woman is having a baby, occasionally, it used to be much more common, I think it's still done occasionally, where there's an inhaling device that has nitrous oxide, a safe dose of nitrous oxide that the person can actually give themselves. And the advantage there is the person has to hold the mask up to their mouth and nose. And if there is the patient starts falling a little too asleep, then they'll just drop the mask and not give themselves a dangerous overdose. Next on the continuum is a deep sedation, which we also call monitored anesthesia care, and that might be a procedure that could be done under local or minimal sedation, but because of either just considerations that we want the patient to be comfortable and if you have a good experience, we give a deeper sedation, and occasionally the sedation has to be a little bit deeper because the local anesthesia is just not enough. Like, for example, there's no local anesthesia that can numb a person up for an upper endoscopy or a gastroscopy or a colonoscopy. So we give deeper sedation, and then the continuum between what we call monitored anesthesia care and general anesthesia starts to become blurred, and it's mostly just something that is related to billing or something like that, but it's a continuous um, there's no real line between one and the other. That's why it's important that deep sedation really only be done by an anesthesiologist or a nurse anesthetist, because a patient may sometimes become deeper than is really safely monitored just by the physician alone. General anesthesia causes unconsciousness and a pain-free state, and a person doesn't necessarily have to have an endotracheal tube. They can have another kind of airway or just oxygen by a nasal cannula and still have general anesthesia and may be breathing on their own. But because it's deeper, they have to be monitored in a more rigorous way. And the medications are then a wide variety that can be either intravenous or inhaled. Another thing that's completely different is what we call regional anesthesia, and hopefully you all are familiar with that. I'm talking about a spinal, where a person is numb from the waist or the middle of the chest down, and the same thing with an epidural, which is a slightly different technique. And then now commonly we're using other types of nerve blocks in the upper part of the body, so there can be injections in the upper part of the back that can numb the chest for maybe breast surgery, or also some kinds of abdominal surgery. And these are frequently used for post-op pain control in conjunction with general anesthesia, and also upper extremities, so we can do injections in and around the neck and upper chest area that will numb the arm up completely. And then a person may need only mild sedation or, again, general anesthesia. The general anesthesia is mostly just because sometimes we don't have really good access to help somebody if they stop breathing or aren't breathing enough. So we'll just start breathing for them and give them general anesthesia from the beginning of the case, so that that's not a concern. So how safe is general anesthesia? Fortunately, there's been a historical decline in mortality rates. In the 1940s, it was still considered quite dangerous, with the death rate listed as about 1 in 1,000 procedures. By the 70s, things had improved to the point when it was 1 in 10,000. And by the 1990s to 2000s, it was 1 in 100,000, and has continued to become safer and safer until now. It's almost difficult to evaluate because there's only maybe a couple of hundred deaths in a year in the United States. So it's probably considerably less than 1 in 100,000 cases. So I would say it's very safe. I usually tell people who are quite frightened by the idea that once they're in the hospital, they've already made it through the most dangerous part of the procedure, which was the drive there. But there are other concerns with general anesthesia. Just because it's not a big risk of death doesn't mean there can't be other complications. There still can be heart attacks or strokes, although again, these are getting pretty rare. And we're not talking about just during the procedure. There's like an elevated risk time after surgery, depending on the surgery. There's some increase in blood clotting that occurs when a person has a wound, and this can be generalized, so that can lead to a possible heart attack, maybe even several days after the surgery. And then there are also risks of fluid changes, dehydration, things like that can lead to kidney injuries. Again, these are much more common in much more major, let's say, big cancer surgery or some other kind of open heart surgery or things like that. But they are concerned, and why people have to be monitored sometimes for several days afterwards. Well, hopefully everybody is aware that blood clots in the legs and going to the lungs is a risk anytime somebody's motionless for a period of time. So these are things that we have to worry about. The brain is also somewhat at risk after prolonged anesthesia and surgery. So sometimes people are confused or somehow otherwise affected after surgery. If it's a short term later, also you have to remember that there's other medications given, like pain medications afterwards, that have their own risks. So if somebody's confused or otherwise not quite right in the head, and it only lasts maybe a few hours to a few days, that's called postoperative delirium. And there's a lot of effort being done now to minimize the risk of that. I've been told for years, although it's been less lately, but somebody says they had a relative who had surgery, and they woke up and they were not quite where they were mentally beforehand, and they just never regained it. This is sort of a confusing situation that is being studied more and more. And with the current ability to keep people totally stable as far as heart rate and blood pressure and things like that, I think hopefully it is also getting less common. But it is a valid concern and something that should be discussed with the anesthesiologist and surgeon before surgery, especially if somebody is already experiencing mild dementia. Again, because people have to be laying in one position for possibly many hours during surgery, we're worried about abnormal pressure on the nerves, and this can, and sometimes positioning. For example, if somebody is laying, having chest surgery on the lung, they might be on their side in a way that requires their arm to be up over their head like this. So we try to avoid that actually, because stretching on the nerves going to the arm can happen. Obviously, it's not going to happen just in a few minutes, but if you're there like for 5 hours, you can actually get more long-term and even permanent injuries. So the way a patient is positioned and pressure on the nerves is always something we're concerned about. As far as the history of anesthesia, it's pretty interesting. It was developed here in the United States. It's one of the few parts of medicine that were actually started in the United States. Obviously, anatomy and other parts of medicine were studied for hundreds of years, and so Europe and the rest of the world might have had a little bit of a head start to the US that's only 250 years old. But anesthesia started in the 1840s and was first developed and publicized here in the US. There was a couple of efforts in the early 1840s to use ether or chloroform, but because it was done by one or two people and never really published or broadcast to the rest of the world, we don't really count that. So the first known public display of anesthesia that was recognized and then published was in October of 1846 at Massachusetts General Hospital. And that was done by a dentist named Morton, and the surgeon was Warren, who's here, you can see, taking a tumor out of the neck of this patient. And this is a famous painting in this operating theater called the Ether Dome. So chloroform, ether, and nitrous oxide were all very rapidly adopted here in the US, and within 10 years was really commonly used throughout the world. And then that was done for quite a few years, about 50 or 60 years. And then after 1920, you can see a tremendous amount of research was done by different drug companies to develop better, safer, more effective, less side effects, and every few years new drugs were introduced, and that has continued until we have currently one drug that is an inhaled drug called sevoflurane, which is extremely effective, safe, causes very little nausea. Some of these previous drugs that are on this list worked pretty well, but still caused a lot of nausea, didn't come on and off as quickly, and several of them were actually very flammable, so you could have risks of fires and even explosions when these drugs were used in the operating room. So that's about all I have to talk about as far as anesthesia, general anesthesia, although hopefully we can get to any questions later on. I'll give you a few other concerns and things that techniques. But I just want to go through it in order. So before a person has surgery, they go through preoperative testing. And what does that entail? So there's going to be a history and limited physical. Sometimes that's done by a nurse, sometimes by an anesthesiologist. There's then standard testing that's frequently ordered depending on the surgery, the age of the patient, and the patient's previous history. So obviously a diabetic will need different testing than somebody who's young and has no medical history. And then it depends on the surgery as well. Somebody who's having open heart surgery might need different testing beforehand than somebody having just surgery to treat a broken arm or something like that, even if it's semi-elective. Obviously, surgery that is being done emergently needs less testing because the surgery has to proceed, urgently, no matter what. There's other patient preparation that is being done more and more often. So we're, as part of the preoperative evaluation, the current medications that somebody is on, there needs to be instructions given. Should you hold these medications? Should you take them like normal? Should you modify the amount of time that you take before the surgery? These are all instructions that a person should get before surgery, either from the surgeon or from the person who's doing the preoperative testing. One new problem that's come up in the last year or so are the GLP-1 inhibitors that people take for diabetes or obesity. And the reason is, part of the reason they use them is because it modifies the gastric emptying. It slows it down drastically. And because these drugs have a very long half-life in the body, a lot of them are given only once a week or so, then we want to make sure that the stomach is empty before surgery. And so then these instructions have to be given significantly ahead of time. And we hate it if we have to cancel a case because somebody took their GLP-1 maybe the day before or 2 or 3 days before, and they weren't told that they need to hold it for at least a week or even longer beforehand. So beforehand, we complete and review the testing. Sometimes when a person comes for preoperative testing, we find something that has to be modified. Maybe their asthma is not under well control, or we're not really sure their cardiac situation. Maybe they had a heart attack several months ago, and we need to find out, are they stable or what? So we want to make sure that all these testing, any extra testing or evaluation is done early enough ahead of time. So if somebody's recommended to go see their cardiologist or their pulmonologist or their kidney doctors, that plenty of time is available so that that can be done before the surgery. And any additional testing or treatment is done ahead of time as well. So if somebody's seen in preoperative clinic, 2 days before, sometimes that's not adequate. It's also been shown, everybody knows that like if you have a knee replacement or a hip, something like that, you might need rehab afterwards. But now we want to make sure that people are in as good a shape as possible. We call it optimization. So sometimes you might want to do a physical type rehab before surgery to make sure you're nice and strong and able to recover well afterwards. And we call that prehab, which is being recommended more and more. And then instructions on not eating or other special instructions like I just talked about. And I just want to mention that the reason some people aren't really aware of why they have to not eat before surgery. And the reason is because when you're under general anesthesia, it's not like just eating and going to sleep like a normal night. If you eat beforehand and you go to sleep at night, you're able to still swallow and and you don't have to worry about aspirating into your stomach while you're sleeping. But under general anesthesia, you don't have those normal reflexes. So if you have some regurgitation into the back of the throat or up into the larynx, then it's definitely possible to just aspirate into the lungs, which can cause a pneumonia and a lot of complications. So nobody wants that. So for elective surgery, you want to make sure that your stomach is empty. So now just a little more into how anesthesia is done. So what to expect when you go into the operating room. So you will get we used to give a pre-medication. So if somebody was in the hospital the night before or went to a pre-admission area, they would get some medication so that they may not remember anything after that, and to eliminate any anxiety and pain that a person is in before surgery. I don't know if it's good or bad, but we don't do this much anymore. So a lot of times bring somebody into the operating room and they'll sort of be a little bit alarmed and say, I don't remember any of this last time I had surgery 5 or 10 years ago. And, all I can say is, well, that's how it was then. And this is how it is now, where we want to maybe minimize extra medications. People tend to sometimes just walk into the operating room. So obviously we need to have people stable and able to walk. So I guess that's that's the way it is. We do put on the monitors before anesthesia is induced, although sometimes while the monitors are being put on, we will give a little medication. So kind of Valium type medicine to help people with anxiety, and then also make it so that they don't remember the whole rest of the procedure. So once the monitors are put on, which basically encompasses the electrocardiogram pads, the blood pressure cuff that works automatically, and the little probe that goes on the finger that gives us your heart rate and the oxygenation of the blood. So I think after COVID and after people have watched a lot of medical shows, people are getting more and more familiar with this kind of thing. So that's done before anesthesia is started. The anesthesia start is called induction, and that is the medication that basically makes you go off to sleep. If we're planning on putting the breathing tube in, this is the time when the medication is given and enough medication is given, including the paralyzing drugs, so the person's not moving, not breathing. We take over. So we put the mask over your mouth and nose, and then actually take over breathing with a bag like you have seen in emergency medicine and things like that. Although we're hooked up to a machine, not just the ambu bag that you see in the emergency setting or out in the field. We can start giving gas at that point, but basically somebody's kept asleep just long enough that we're able to do the what's called the intubation. I'll show you a little bit more about that in a second. Then there's the maintenance part, where we make sure we give the person enough medication, fluids, monitor the heart rate, blood pressure, oxygenation, make sure that they're unconscious, and make sure that any trauma that's being given by the surgeon is being compensated for. So if the person needs more fluids or a blood transfusion or anything else, we are monitoring and maintaining that for the duration of the surgery. And then when the surgery is over, the person is gradually woken up, and that's called emergence. And this whole procedure has been compared to being a pilot on a plane, where you have the takeoff, the landing, and then obviously the flight in between. So, one of the more intense parts of a plane is the takeoff and landing, and for us, it's the induction and emergence. So how do we start out? So before the patient ever gets to the room, and one of the sort of negatives about anesthesia is you have to get there really early and prepare. So surgeries that start at 7 or 7:30, we have to get there maybe up to half hour or 45 minutes ahead of time to set the room up. So we go through a check on the machine, which is part manual, part automatic. We have to inspect the hoses, connections, prepare and test suction, because we always have to have kind of a suction available. We have backup systems that need to make sure that they're in place. For example, you can see here on this picture on the right side, there's in a bag an ambu bag in case the machine has a malfunction and then the backup systems have malfunctions. We can also go to just plain ambu bag ventilation. We have different types of airway equipment that have to be prepared and make sure that they're in good working order. And then our medications are frequently drawn up into a syringe ahead of time, and as well as the monitors that we're planning on using. Pre-medications include anti-anxiety, pain medications. We have medications to neutralize stomach acid, which are sometimes used before emergency surgery or people who have bad reflux disease. We give antibiotic prophylaxis that just minimize the risk of infection during surgery, although obviously sterile technique is used throughout, but it's been shown that giving an antibiotic at the beginning of surgery or before the surgery decreases in post-infections even more so. And then depending on maybe a person's proclivity towards problems ahead of time, we are monitoring and checking for blood sugar and blood pressure and things like that. The medications we use are a variety of anesthetics, both intravenous and inhaled, although, like I said, we're really down to basically one medication now. Nitrous oxide is still available, but at least in my institution, it's not really used that much because it did still cause nausea, and we're really trying to minimize any side effect, and sevoflurane is just so fast onset, just goes away out of the system so quickly and causes such few complications. We do use medications to basically paralyze the muscles so that a patient doesn't move even in the face of full anesthetic. And these are fully reversed before the end of the case. There's also anti-nausea given in addition to drugs that really don't cause much nausea. So it used to be even 10 years ago that nausea was our biggest complication that we worked hard to avoid. And I think nowadays nausea is getting fairly rare. However, surgery still causes pain afterwards, so a lot of our focus now is on decreasing pain. We have different pain medications, and we're increasingly using nerve blocks so that the patient has numbness afterwards, decreases the amount of anesthesia that has to be given, again, decreasing the amount of side effects, and making sure that the patient is comfortable for at least a few hours to even more than a day afterwards. At the end of the surgery, like I said, we reverse these muscle relaxants or paralyzing drugs. We make sure that the blood pressure is controlled throughout, and other cardiac medication, depending on the surgery, might be given throughout the surgery and in the postoperative unit. I just wanted to make sure you're all familiar with what's done when we do control the airway with the endotracheal tube. A lot of times you start out with the mask just over the nose and mouth, but obviously Depending on the patient position, depending on where the surgery is being done, we may not have access to keep the mask there. Plus, we may want to make sure that we're controlling the respirations and that there's no leakage of anesthesia, inhaled drugs into the room. We don't want the surgeon falling asleep or the risk of having anesthetic gases to people who work in the operating room, because there is some possibility that prolonged exposure over many years can cause maybe slightly increased cancer risk, although this is really controversial. So we put in the endotracheal tube. You can see the balloon there, makes for a tight seal. Also saves on the amount of medication that's used because these are expensive medications. So the tube is put in, and we're very good at that. And it's used. It's done with this this electronic or this mechanical device called a laryngoscope. You see it done in the emergency room and on these TV shows in the field. And so a lot of people are trained in using it besides anesthesiologists. Although because we do it multiple times every day, we're still considered the airway experts. So if somebody needs to have an endotracheal tube put in the hospital for some reason, and this was big during COVID, anesthesiologist is frequently called. But there are other doctors like emergency room doctors and intensive care unit doctors that are trained to put these in as well. This is a picture that somebody putting in an endotracheal tube with a laryngoscope. But there's also, like with everything, there's new ways to do this. So there are devices now used where, before the person had to look right in the airway and see exactly where to put the tube. And not everybody is equally, has the same anatomy, so sometimes more difficult than others. And there's a whole science of what we call difficult airways, where it might be difficult or near impossible to use a regular laryngoscope. And there's video laryngoscopy and other techniques that we're trained on. And might be how this looks now. And a lot of people have gone to using the video laryngoscope a lot more often. So there's anesthesiologists who rarely do the direct laryngoscopy with that device that I just showed you before. So I told you about monitoring. What are we actually monitoring, and what's on the screens that you see? So we are monitoring continuous EKG. So where you get an EKG in the doctor's office that might cover you for less than a minute. We use EKG throughout surgery, so it might go on for hours, and we're watching that all the time. That gives us the heart rate as well, and gives us and then we're monitoring the blood pressure, either with an automatic blood pressure cuff or a type of an IV type thing, so an actual catheter that goes into the artery and can monitor blood pressure continuously. We're monitoring ventilation, so when you're breathing, we're watching devices that are telling us every breath that you take, every time you exhale. We're measuring the carbon dioxide, so we know how fast you're breathing, how deeply you're breathing, how effective you're breathing, the oxygenation, so the level of oxygen and CO2 and nitrous oxide and nitrogen that's going in and out of your body. We're monitoring the level of the anesthetic gas that you're breathing. So we're knowing basically what's happening every breath. We're also monitoring temperature, making sure the temperature doesn't go too low because it's cold in the operating room, and there's complications where people actually get drastic increases in temperature, which can be a very dangerous thing. The muscle relaxation that I talked about before, being paralyzed, is something that we want to make sure is adequate, not too much or not too little during the surgery. And there are actually devices that we put on the muscles that then tell us how deep the muscle relaxation is. And then for quite a few years now, we have devices that go on the forehead or other parts of the head that tell us your electroencephalogram. So it actually is like an EEG, but it measures the brain waves of the waves of the electrical waves of the brain. There are EEGs done for people who have seizures, or if somebody's in the intensive care unit and need to be monitored, how well is their brain actually working? So that now we've modified this all to be able to monitor how asleep somebody is, and that's improving all the time, so that we can tell if somebody is under anesthesia effectively, and not getting too much anesthesia, but getting enough, and also being aware that they're totally awake when the surgery is over. After the whole thing is done, then the person goes to a post-anesthetic care unit. These are specially trained nurses who know what to look for somebody who just woke up for general anesthesia. So continuation of intensive care, if somebody had a big surgery and are really, they may still have the endotracheal tube in place, still be on a ventilator, and or they may be pretty wide awake and just have to be there for a few minutes before they go home. Obviously, there's gigantic variation between somebody who just had like cataract surgery and was pretty much awake the whole time and did not have any big changes to their body except for the little area of their surgery, all the way to somebody who had open heart surgery or big lung surgery or something like that. So appropriate post-anesthesia care monitoring is done. So a few other details I just want to tell you about. Who's giving you the anesthesia? And like I said, I'm an anesthesiologist, I'm a medical doctor. I went to college, I went to medical school for 4 years. I did internship. There's a residency of anesthesia that is 3 years. And then some people do a further training after that called a fellowship. So they might have an extra training in pediatric anesthesia or OB anesthesia, or these nerve blocks that they call regional anesthesia fellowships that are super popular now. People do pain management. I did a pain management extra fellowship. I personally actually didn't go directly to my anesthesia training. I started out as a general internist, so I had done another residency in internal medicine before I ever went, and then I practiced before I went to my anesthesia residency. So that is the training of a physician anesthesiologist. So a nurse anesthetist that could be giving you anesthesia sometimes works as a team with an anesthesiologist, but depending on the laws and regulations of the place and depending on the state that you're in, a nurse anesthetist may need to be monitored by an anesthesiologist, may be monitored by a physician who's not an anesthesiologist, has no anesthesia training, or may be working totally independent. And because anesthesia is so safe, and because it's gotten a lot, I don't know, easier, I would have to say, over the years, and also because of tradition. Nurse anesthetists now can be working totally independently, and have also a very good safety profile. I would have to say, in New Jersey, the regulations are stricter than a lot of other places, so it's unlikely that you're going to have a nurse anesthetist working independently. Although because the VA has a totally separate system and is not under state control, if you were at a VA hospital, a nurse anesthetist can work independently. Going back to the history, because of the way history worked, people trained to be surgeons or ophthalmologists or obstetricians, although there were general physicians for many years. But I would say over the last 50 or even 80 years, there's been a lot of specialization. But anesthesia was one of the last doctors to get specialized. So we're only at the 50-year anniversary of the first independent anesthesia departments in academic medicine. So, if you were having surgery 80 years ago, for example, or even less, you would probably have just the least trained person giving you the ether or whatever anesthesia was going on at the time. So you might have a general practitioner who was just looking for extra money, or maybe a surgery intern or a resident that wasn't needed to do the surgery, but he might be just told to give the anesthesia and be given, some minimal on-the-job training, believe it or not. So that was what the history of anesthesia is, and obviously that's a lot different now. Some of the newer things is ultrasound. Everybody, I think most people have known they might get an ultrasound of their gallbladder or get a hard ultrasound called an echocardiogram. Now, ultrasound is being used a lot more as point of care. So more physicians are getting them in their office to see, like, if you come in with, cough and shortness of breath, you might have an ultrasound test done in your doctor's office to tell if you have a pneumonia. You might not need an x-ray. And this is being done in anesthesia also, to either put in different kinds of IVs or central lines that go into the heart, or these different nerve blocks that we do. So ultrasound is becoming more and more prevalent in all kinds of different care, both for diagnosis and for treatment. Like, for example, an injection in the knee used to be done just by the doctor injecting where he thought the knee joint was. Now they use frequently ultrasound to show them exactly. This is an example of somebody who has maybe a lot of extra fluid on board, or has had so many IVs that the veins are hard to find, and they can use ultrasound to guide even a peripheral IV. So that's what I had planned, and if anybody has any questions, I will be happy to take them now.